Welcome again, guys. So this is Dr. Viva again. We will be discussing how to write perfect answers for dislocation type of radiographs in today's session. Okay. So we'll try to finish it as early as possible. So you guys should also be saving time, and it is easy for you to watch to gather all the information what you need to write in your final FRCR to be shorts component of the examination. So the attempt over here after watching this particular video, you should be aiming for at least 4 out of 5 or 5 out of 5 if you write a perfect answer. Okay. The next thing that you should be knowing is how to differentiate subluxation versus dislocation. So if there is complete loss of normal articulation between two opposing joint surfaces, that means 100%. There is no overlap of even 10% of the joint surfaces, that means there is a dislocation. Okay. In contrary to dislocation, there is another entity which is known as subluxation. If there is loss of articulation but not up to the 100%, less than 100%, then you call it subluxation. So the definition of subluxation is the joint surfaces slip out of alignment but remain partially in contact. So not 100% slippage out, less than 100% if a part of the joint surfaces, articulating surfaces remains in contact, then you call it subluxation. Okay. And in subluxation radiographs, the subluxated bones, they spontaneously return to their correct position. So at least two views are required to call subluxation, and to nicely categorize subluxation into what kind of subluxation are you looking for, whether are there any associated fractures associated with subluxation. At least two orthogonal views are required, most likely frontal and the lateral projection. So without waiting anymore, this is how your model answer should look like in cases of dislocation. So in findings, you need to write what kind of dislocation are you dealing with, which is the joint involved, whether is it a shoulder joint or ankle joint or elbow joint, whether there are any associated fractures in that particular type of dislocation. If there is any joint effusion, how to identify joint effusion, if there is any soft tissue swelling or a vascular necrosis, if any. Okay. You need to write briefly about what kind of dislocation you are seeing and write it in the impression part. In the management part, you have to write urgent orthopedic referral, then analgesia. You have to look for neurovascular assessment, and depending upon whether the dislocation is managed conservatively or surgically. So most of the 90% of dislocations are managed conservatively, and surgical fixation is only required if there is any associated fracture or instability. Okay. Many of the students, 90% of students, they fail to write post reduction radiographs. So keep it in mind in all the cases of dislocations, whenever orthopedician fixes or relocates the joint, dislocated joint, he or she gets a post reduction radiograph to confirm whether the alignment of the joint surfaces are good or not. Okay. So the first point of today's lecture is type of dislocation, how to identify dislocation. So coming to the dislocation, so what is the definition of dislocation first? We'll come in the next slides to see what kind of dislocation you should label depending upon the displacement of the bones. Okay. So dislocation types, they depend upon how the distal articulating bone shifts relative to the proximal socket. Okay. So the dislocation in rest of the body, there is one exception to it. We'll come to that in the next slide. In whole of the body, dislocations are labeled on the basis of what is the movement of distal articulating bone, okay, as compared to the proximal joint, as compared to the proximal bone or proximal socket. You should remember the distal articulating bone is important. Okay. There is only one exception to it. We'll discuss that in the next slides. So depending upon the movement of the distal articulating bone, the types of dislocations are classified into anterior dislocation, posterior dislocation, superior, inferior, medial, and lateral. So on the basis of where is the distal articulating bone has moved, So depending upon that, the dislocations are classified into 6 types. Now coming to the exception part. So in exception part, spine is the exception. Spine is the only bone where the dislocations are mentioned when the proximal articulating bone shifts relative to the distal one. That means the upper vertebra, the superior vertebra is taken into account and it is referred in cases of spinal dislocations. Otherwise, if you are not dealing with spine dislocation in the rest of the body, it is always distal articulating bone which is given importance as far as labeling of the dislocation is concerned. Only in cases of spine, the proximal articulating bone, the superior vertebra, is given more importance as compared to the distal one. Okay, this you should remember. We always talk about anterolisthesis of L3 over L4. We never talk about retrolisthesis of L4 over L3. Okay, that is how you are going to remember. So coming to the first part, what is anterior dislocation? Here I have attempted to make it simple and to show you schematic diagrams on how to identify anterior dislocation. So what is the definition of anterior dislocation first? A joint injury where the distal articulating bone shifts anterior. Okay, so we are talking about distal articulating bone shifting anteriorly. So these are the two projections, frontal projection and lateral projection. This is the proximal bone, this is the joint, this is the distal bone, and this is the lateral projection. This is the anterior aspect of the radiograph, and this is the posterior. So here, as you can see, the distal articulating bone is shifting anteriorly. So that is the reason we are labeling it as anterior dislocation. Okay, understood? Now we'll move on to posterior dislocation. So in shoulder joint, it is predominantly anterior dislocation that is more common. Posterior dislocations are more common in hip joints. Okay, so what is the definition of posterior dislocation? A joint injury where the distal articulating bone shifts posterior, backward. Okay, so this is the frontal radiograph. In frontal radiograph, it is difficult to identify anterior and posterior dislocation. Only on the lateral radiograph, it is easy to tell whether the distal articulating bone has slipped anteriorly or posteriorly. Here on the lateral radiograph, for the sake of understanding, I have drawn these schematic diagrams. Here, see on the lateral radiograph, the distal articulating bone has shifted posteriorly. Okay, so that is the reason we are labeling this as posterior dislocation. Now coming to superior dislocation, so superior dislocation is a type of joint injury where the distal articulating bone shifts superiorly upwards. Okay, so this is a classical example of the glenohumeral joint over here. For the purpose of understanding, I have taken glenohumeral joint. So over here, this is the humeral head. This has shifted superiorly. Okay, ideally the humeral head should have been in the glenoid socket. So there is superior subluxation. On the lateral radiograph, you will see superimposition of the humerus over the scapula. Okay, this is how you are going to see superiorly dislocated humerus on the frontal projection and on the lateral projection. Understood? Now coming to the inferior dislocation. So inferior dislocation, what happens? The humeral head slips out of the glenohumeral joint and slips inferiorly. So that is the reason we are labeling it as inferior dislocation, because the distal articulating bone has shifted inferiorly. Okay, on the lateral radiograph, you can see open glenoid socket and the humeral head is displaced inferiorly. So this is known as inferior dislocation. Now coming to the next part, what is medial dislocation? So medial dislocation is a type of joint injury where the distal articulating bone shifts medially. So this is superior, this is inferior, this is medial lateral, this is proximal bone, this is joint, this is distal bone. When the distal bone is shifted medially, okay, then you have to label it as medial dislocation. On lateral radiograph, it is difficult to identify medial dislocation, but on the frontal radiograph, medial dislocation is very apparent and you can confidently label it also. Coming to the last part, what is known as lateral dislocation? Lateral dislocation is a joint injury where the distal articulating bone shifts laterally. So this is the superior, medial, lateral. So this is the distal articulating bone. It has shifted laterally. That is the reason we are labeling this as lateral dislocation. On the lateral radiograph, it is difficult to see lateral dislocation, but for the purpose of understanding, I have drawn this schematic diagram, so you should be able to understand on frontal and lateral projections how the dislocation, various types of dislocation will look like. Now coming to the next part, which joints are involved. Okay, so you have to mention it in the report which joint is involved. So most common joints which are involved in dislocations are shoulder joint is the most common joint, then elbow joint, hip joint, knee joint. Particularly in the knee joint, patella is the most commonly dislocated bone, and joints of the hand. Now coming to associated fractures. Are there any associated fractures? So you have to mention it in the report, because if there are any significant chunky volume of associated fractures, then the surgeon has to repair it surgically. Okay, so mentioning associated fractures are important even in your day-to-day practice. So what associated fractures are you worried about? If there is any shoulder dislocation, then you have to look for whether there is any greater tuberosity fracture. And in shoulder dislocation cases, majority of the times there will be Bankhart's lesion and Hill-Sachs defect. On the radiograph, soft tissue Bankhart's lesion are difficult to identify, but if there are any bony Bankhart's, then large bony Bankhart's, then you can identify it. Okay, if you are dealing with elbow dislocation, you have to look for any radial head fractures or coronary process of ulna fracture. If you are dealing with hip joints dislocation, then you have to look for whether there is any acetabular fractures, any anterior posterior lip of acetabulum is involved, or whether there any femoral head fracture, whether there is any osteochondral injury of the femoral head. If there is any ankle dislocation, then you have to look for which malleolus is involved. Any malleolar fracture is there, medial, lateral, or posterior malleolar fractures in cases of ankle dislocation. Now coming to the next part, how to identify joint effusions, whether in cases of dislocation do you see joint effusion or not. So joint effusion is an abnormal accumulation of fluid within the joint capsule, commonly seen following acute dislocation due to capsular or synovial injury. So mentioning joint effusions on the radiograph is difficult, because it is not an MRI. There are only indirect signs to mention joint effusion in the radiograph. So these indirect signs are there. You might see increased soft tissue density surrounding the joint, radio opacity surrounding the joint. You might be seeing capsular distension or any fat pad displacement. Okay, fat pad displacement is the most commonly used sign, radiological sign, in order to comment upon whether there is joint effusion or not. This is normal radiograph of the knee joint, where you can see lateral fat, medial fat pad, and suprapatellar fat pad. Okay, if there is any associated joint effusion in cases of fractures, you should be seeing convexity of medial fat pad, lateral fat pad, and suprapatellar fat pad. Coming to the elbow joint, so these we know how the anterior and posterior fat pads are seen on the lateral radiograph of the elbow joint. And if you see elevation of the posterior fat pad, and visibly if you are not seeing fracture, that means there is underlying occult fracture. Okay, in order to identify occult fracture, you have to get radiograph after 7 days, because after 7 days you will see periosteal reaction, and you can confidently say whether there is any supracondylar fracture, or whether there is any intercondylar fracture, or different kinds of fracture involving intra-articular surfaces of the elbow joint. Now coming to the soft tissue swelling. So what soft tissue swelling are that you should be talking about? So if you see any dislocation of the joint, you have to mention that is there any increase in the volume of the soft tissue or radio opacity surrounding the joint. Okay, what are the signs? The signs could be increased soft tissue thickness around the affected joint, loss of normal soft tissue planes, and may be only clue to an occult injury. Okay, if you are seeing soft tissue swelling around the knee joint, you can raise a possibility that occult fracture or hairline fractures cannot be completely ruled out. Follow-up X-ray is advised after 7 days, so that you will be able to appreciate any associated periosteal reaction, and then you can retrospectively say that there might have been fracture of that particular part of the bone. Coming to the last part, if there is any avascular necrosis. Okay, so avascular necrosis is the late complication of dislocation. In early radiographs, it is difficult to identify avascular necrosis. So this is acute radiograph of the patient or dislocated hip joint. This is posterior dislocation of the left hip joint, posterior superior dislocation. Here in such cases, you have to look for whether there is any femoral head fracture or any posterior lip of the acetabular fracture. And when it was relocated, after some days, repeat radiograph was performed. In the repeat radiograph, you can see increased sclerosis, articular surface irregularities involving femoral head and raising a suspicion of avascular necrosis. So what is avascular necrosis? Avascular necrosis is ischemic death of the bone due to interruption to its blood supply. It is a serious complication of joint dislocation, particularly when the reduction is delayed. Okay. And the signs, radiological signs, you can see there might be increased sclerosis, subchondral lucency, crescent formation or crescent sign. There might be in late stages, you can see flattening of the femoral head or collapse of the articular surface. Now coming to the management, in management part, you need to write everything. Okay. Particularly the importance will be, I would say that many of you will forget to write post reduction radiograph, but after listening, after watching to this particular video, at least try to remember that you will acquire post reduction radiograph in all the cases of dislocation of the joint. So the first thing you have to mention it in the report that urgent orthopedic referral, we are all doing that. Then analgesia, whether there is any neurovascular problem in the dislocated joint. So you have to look for the distal pulses. Okay. If there is any neurovascular compromise, then you will have to get the CT angiography done. Close reduction wherever appropriate. In most of the 90% of cases, close reduction is done and the dislocated joint is relocated. Surgical fixation is only reserved for candidates where there are any large associated fractures and where there is any instability. Okay. So that is all, guys. I will be uploading this video on FRCR Shorts YouTube channel shortly. Maybe next thing, I think we'll have to move on to another system now, such as a respiratory system, where we are going to discuss everything in detail, where how to mention various kinds of masses on the radiograph, what signs you should be knowing, what are the signs of collapse, how to identify collapse on the radiograph. So we are going to discuss about that. Thank you, guys. See you next time.